Welcome and thank you for standing by. At this time, all lines are in a listen-only mode. During the Q&A session, you may press star 1 on your touch-tone phone to ask a question. Today's conference is being recorded. If you have any objections at this time, you may disconnect. I would now like to turn the meeting over to Dr. Matthew Golden. Sir, you may begin.
Thank you very much. Good morning. Welcome to the very first Prevention Science Series lecture of 2014. It gives me tremendous pleasure to introduce to you Matthew Golden, who probably needs no introduction to anybody in the room today, but Matt is the director of the Public Health Seattle and King County HIV STD Control Program. He was being referred to by Drs. Jana Merman and Gail Boland yesterday, or on Wednesday, as the primary program scientist in the country. So given our recent initiative, I think it's very appropriate that we have Matthew to talk to us. The research he conducts, by and large, focuses on operational research evaluating new public health interventions to control STDs and HIV. And the most recent projects include a trial of expedited partner therapy for gonorrhea and chlamydia, a program to increase antiretroviral use to prevent HIV transmission, a cohort study of young men who have sex with men, and studies related to HIV testing, and many, many different kinds of surveillance projects. Matt got his education at Johns Hopkins University, both his MD and his MPH, and he was also trained at the University of Washington. With that, Matt, thank you so much for being here.
Thank you, Sevgi, and it's nice to be here. It's always an honor to come to CDC and be surrounded by so many longtime friends and colleagues. The title of my talk is From Partner Services to Field Services, the Evolving Role of Public Health Outreach in the Control of HIV-STD. And what I'd like to do is start initially by talking about expedited partner therapy for gonorrhea and chlamydia. And I'm going to very quickly summarize what we learned prior to 2010 and then mostly focus on the Washington State EPT community level trial. Then talk about the expanding scope of STD partner services, and then analogously, what I think is the expanding scope of HIV partner services. And then finally, there's a few conclusions about our transition from partner services to field services. I suspect most of this is well known to people in the audience, but there may be some people over the internet who are less familiar with this area. So when I talk about partner services, what I'm talking about is clinical and public health efforts to ensure the treatment of potentially exposed sex partners of persons with STIs. And in the United States, this is mostly undertaken by disease intervention specialists, or DIS, who are public health outreach staff who conduct partner services investigations. In several parts of the talk, I'm going to refer to number needed to investigate, or NNTI, which is similar to the metric of number needed to treat in clinical epidemiology, and refers to the number of people that field services staff need to investigate to achieve an outcome, like a new case of HIV identified or identifying a person who's out of care. So I originally got involved in this area of research in the late 1990s, actually mostly in response to a CDC RFP that Sevgi and Jen St. Lawrence and Judy Wasser had put out. That was really about trying to figure out a better approach to getting partners treated with people with gonorrhea and chlamydial infection. And I think that came out of a recognition that there was this mismatch between the resources we had available for partner services and the scale of our problem. And we had an intervention that was developed in the 30s and 40s to control syphilis that was very resource intensive. And as gonorrhea and chlamydia were added to the STD control agenda, what we ended up with is a country with about 1.8 million cases of reportable STI annually. And if we had wanted to provide complete partner services or anything close to that to all of these people, we'd be spending over $200 million a year on DIS, and there was no way that was going to happen. What we ended up focusing on is what's now called expedited partner therapy, and that refers to, or EPT, which refers to treating the sex partners of people without requiring their mandatory clinical evaluation first. And in most instances, that means patient-delivered partner therapy, or PDPT, which is about giving people medications or prescriptions for medications to give to their sex partners. We've now had 3 randomized controlled trials of EPT-related interventions in the United States and a 4th trial conducted in Scotland. And the results of those trials are summarized here, looking at the outcome of persistent or recurrent gonorrhea or chlamydial infection. And what I think you can appreciate is across the 3 trials all showed either a statistically significant decline in persistent or recurrent infection or a trend towards such a decline. And overall, across the studies and meta-analysis, what you see is about a 25% reduction in recurrent or persistent infection. Now, that outcome actually differs quite substantially between gonorrhea and chlamydia. So here, looking at this, the data stratified, the upper panel is looking at persistent recurrent gonorrhea, and the lower panel, persistent recurrent chlamydial infection. And what you can see is that the 2 trials, across the 2 trials that looked at it, the risk reduction for gonorrhea is about 65%. That's an absolute risk reduction of 9% in the risk of reinfection in about 12 weeks, so a huge effect size. Whereas the effect for chlamydia, none of the trials actually observed statistically significant effect for chlamydia alone. Across the trials and meta-analysis, you do see a statistically significant effect, but that effect is closer to a 20% range, so much more modest. And this trial is looking at the behavioral outcomes, the numbers of partners notified or treated. The trials use somewhat different outcomes to gauge this, but what you can see is about a 25% increase in the numbers of partners notified or treated in persons who receive patient-delivered partner therapy compared to those who do not. Tom Gift, who I think is in the audience, collaborated with us and with Patty Kissinger on a study looking at the cost-effectiveness of this intervention. And what I think you can see here is that the intervention is not just cost-effective, but actually cost-saving. So something which is fairly rare in medicine to have an intervention which appears to be cost-saving. That's really true regardless of the perspective one takes in a cost-effectiveness analysis. So by the mid-2000s, where we were at, I think, is that we had an intervention which we knew was associated with individual level benefit. And we knew that benefit was greater for gonorrhea than for chlamydial infection. And we had an intervention that we think increased partner treatment and something that was cost-effective and probably cost-saving. And what we didn't know is whether the intervention was scalable and how it could be made to be scalable. And we didn't know whether it had a population-level effect or what more we would do beyond EPT. And with those ideas in mind, we designed the Washington State Community-Level Randomized Trial of Expedited Partner Therapy. The objectives of this trial were to determine if a program to promote EPT could be brought to scale in a state with 6.5 million inhabitants, and to determine if that program could decrease the prevalence of chlamydia and incidence of gonorrhea in women. This is a step-wedge community-level randomized trial in which local health jurisdictions, or LHJs, are the unit of randomization and analysis. The study involved 23 of the 25 LHJs in Washington State. It didn't involve King County, which is where Seattle is, because the intervention was developed in Seattle, and we really had no way to stop the intervention and then start it again in the city of Seattle. Our primary outcome was chlamydia positivity among women tested in sentinel clinics that were participating in the infertility prevention program, and gonorrhea incidence in women. This slide is showing you a schematic of a step wedge design. So the idea here is that the local health jurisdictions in the state were randomly assigned into 4 different study waves. And the study was then instituted in random order among those waves. Outcomes were measured in each community at each time step, and the observations then were in sync to control for time trends, with analysis comparing variance both between communities and within communities before and after the study intervention. The intervention had 2 components. The first component was that what we were seeking to do was basically buy the meds for all the sex partners for everybody in the entire state. So we made free patient-delivered partner therapy packs available to all medical providers. So these were distributed to large volume providers like Planned Parenthood and family planning clinics, but any medical provider in the state could ask to get these and receive them at no cost. We also stocked them in 157 different commercial pharmacies, which the docs could prescribe the meds from these pharmacies using a pre-printed prescription pad, which was attached to the case report form and was also available in a faxable way. The medications were packaged as you're seeing here. There was an allergy warning in English and Spanish. This all conformed with the requirements of our state pharmacy board. The packs included azithromycin, and for persons with gonorrhea, a 400 milligram dose of cefixime as well. There were some condoms in there and some information about sexually transmitted infections. The second component in intervention was the targeted provision of public health partner services. So what we sought to do was have medical providers triage people at high risk for not ensuring their partner's treatment to receive assistance from our DIS. And what we recommended was people who had more than one sex partner or a partner they're not going to have sex with again, we referred for public health partner services, and those factors have been previously identified as being associated with a very high risk of not getting your partners treated. So for the most part, people with a single sex partner in an ongoing sexual relationship will get their partners treated with relatively little intervention. This was a low-intensity model of partner services. Essentially, all of it was provided via the telephone. We didn't do field investigation. The idea was to offer people assistance notifying partners they didn't want to notify themselves, to offer everybody patient-delivered partner therapy. Now, we did run into a problem, and that is that in 2007, the Washington State Legislature allocated new funds for communicable disease control that some local health jurisdictions used to hire CIS outside of the randomization sequence of the study. Now, when the recession hit, all of those DIS really got laid off. So what didn't prove to be a sustainable intervention by our state, but it did have a potential effect on our study. What you're seeing here is the percentage of heterosexuals with gonorrhea and chlamydial infection receiving public health partner services before and after our study intervention. So the green bars are before, the red bars are during the intervention period. Overall, the proportion of people receiving partner services increased from 25 to 45%. But you can see that that increase was restricted to the first two study waves. In waves 3 and 4, those that occurred after the state put new money into partner services, we didn't see a bump in partner services. No state money, though, during the trial was used to buy patient-delivered partner therapy or promote patient-delivered partner therapy. So we did see a big increase in patient-delivered partner therapy use in all of our study waves. Overall, the proportion of people who received PDBT from their medical provider increased from 18% to 34%. And I would point out to you that among those people who were not referred for public health partner services, 62% received meds from their medical providers to give to their sex partners. In 2010, 38% of all heterosexuals with gonorrhea in the state of Washington were offered medications to give to their sex partners, and 52% of all heterosexuals with chlamydial infection were offered medications to give to their sex partners. So I think we really did achieve an extremely high level of intervention penetrance into the population. This slide is showing you trends in chlamydia positivity in our Sentinel clinic, as well as the trends in the rate of gonorrhea among heterosexuals in Washington State. And as you can see, both of these are showing declines. Both of these declines are statistically significant. So at first blush, this looks really great. But it's a little more complicated than that. So here you're looking at chlamydia positivity among women 15 to 25 in our Sentinel clinic, stratified by study wave. And what I think you can appreciate is in study wave 1, we see sort of a decline and then goes up. In study wave 2, we see what we were hoping to see, which is to say a decline concurrent with institutional intervention. I should say here that the open boxes and dashed lines are the pre-study period, and the closed boxes and solid lines are the intervention period. This shows you the same information for gonorrhea. You can see that they're all declining, but that decline appears to have started prior to institution of the study intervention. So if you look at our main study outcome, which was chlamydia positivity and gonorrhea incidence, although our rate and risk ratios were all less than 1, they were not achieve statistical significance. Our combined outcome, which was actually a post-hoc analysis, had a p-value of 0.06. So again, did not quite achieve statistical significance. Now, one big issue is, was this intervention, is it scalable? Is it sustainable? Well, to buy meds for 10,000 people in the state costs a little over $100,000. So from my perspective, that actually isn't very much money in the state with 6.5 million people in it. To pay for the DIS is over $700,000. And I think that's a pretty big ticket item, not as clear that that is a scalable and sustainable intervention. Here you're looking at the number of patient-delivered partner therapy packs distributed in Washington State between 2008 and 2013. And this area here is the post-study intervention. The point I want to make here is that this intervention has been sustained in Washington State after the study ended and we ceased to have NIH funding for it. So we continue to distribute about 15,000 of these packs per year in the state. We contributed to have our pharmacy network distributing about 5,000 packs per year through that mechanism. So this really has proven to be a sustainable intervention, at least in our state. This slide, Mark Stenger was generous enough to provide me with it, looks at the proportion of heterosexuals receiving PDPT for gonorrhea in different sites participating in SSUN, which is the STD surveillance network. You can see that in Washington State, it's 35.5% of people are receiving these meds. In the next highest state, which is Colorado, it's 10.7%, much lower really everywhere else. So the level of PDPT use, at least for gonorrhea in Washington State, is at least 3 times higher than the next highest state, and many, many-fold higher than the United States as a whole. So what did we learn from this? Well, I think that the promotion of widespread use of PDPT is a scalable and sustainable intervention. We use less PDPT for gonorrhea than chlamydia, which is actually the opposite of what makes sense based on what we've observed in randomized controlled trials. I think that the targeted provision of chlamydia partner service is probably not scalable and sustainable given what the costs are. And I think our data are consistent with a population level effect, but not definitive. But I would also point out to you that there are no STI interventions for which we have community-level randomized controlled trial in high-income countries demonstrating population level effect. So that evidentiary standard is not an evidentiary standard that we have met for anything that we do. So it is a very high standard, and I would say at some level an experimental one. Where do we stand with EPT? Well, I think it's a good solution to the problem we set out to address, which is this mismatch between the scale of the problem and our traditional solution and the resources we had to address it. And I think we made good initial progress in changing the legal environment and creating the tools to promote EPT, which is really a testament to people doing a great job here at CDC more than anything else in moving this along. At the same time, I would say at this point we're sort of stalled in implementation. And the biggest problem to me is who's going to pay for the meds. And there are 2 solutions that I'm aware of, both of which I think have examples in vaccines. And one is we just buy the meds together, which is what we did in Washington State, using 340B pricing, which is public health pricing. I think that makes sense to me. This is a public health problem, and the problem should be addressed as a public health problem. The alternative would be to require or convince all the insurers to pay for the meds for other people's sex partners. That might be possible. I think it could be challenging to make that happen, but I don't know. So I was talking, so far I've been talking about EPT, and I mentioned that to some extent this area of research emanated from a CDC RFA. And a few years ago, you guys put out an RFA for this Category C money. I don't know if you guys know too much about this for HIV. And nothing focuses the mind for people like me like dangling money in front of us and saying, write a grant. So, we start thinking, well, what are the forces shaping change for us now? Well, we've had a big political and economic changes. We've had a huge recession. Much of the country, or some of the country, is still in a recession, leading to diminished state and federal fundings. In many instances, that's led STD clinics to close. We have healthcare reform, which I think means there's probably less categorical funding available for HIV STD, or could be, and that public health is going to need to rely more on insurance. But at the same time, this is really our opportunity to rethink our healthcare system for a population which is insured. We've had scientific and epidemiologic changes. We have a huge HIV STD epidemic in men who have sex with men. We're currently at a point where almost 2/3 of all HIV infections in the United States are occurring in MSM, who represent roughly 2% of the American population. We're not going to eliminate syphilis, and we really need to focus on MSM. I think that the DEBIs are probably not scalable, and that the reality is that although there is certainly a role for counseling in selected populations and to achieve selective outcomes, we are not going to counsel our way out of this epidemic. And part of the lesson of this is that our research has been too disconnected from public health practice. And I think that this whole program science initiative is in part an effort to address that problem. I think we have good evidence that ART prevents HIV transmission, and at this point, case finding and treatment are really our cornerstones of HIV prevention. And we have a focus on this care continuum both in the United States and internationally, as evidenced by the fact that the President announced the care continuum initiative. We also have big changes in public health So we have HIV STD program integration, which for a lot of STD program people, I think has felt quite threatening, actually. But at the same time, HIV is increasingly being seen and treated as a sexually transmitted disease, which maybe provides threats on the other side. And HIV is our priority STD. There is no question about that. And STD control efforts need to advance the objective of HIV control. And all of the money practically is in HIV. So as you think about what are our opportunities in partner services in the second decade of the 21st century, to me the real issue is what is our goal? Why have we been so focused on getting partners treated versus our broader public health objective? So getting partners treated is an important goal, but it's not our only goal. And what else can these field services staff do to really achieve what we want to from a much broader perspective? So I'm going to talk about that, but before I do, I want to orient you to the epidemic where I live in Seattle and Washington State. And the reason why is a lot of the research I'm going to present is from King County, and so it's important to realize, sort of the perspective where we're coming from. So these data are looking at the number of visits to the public health Seattle King County STD clinic between 1993 and 2012. The yellow line is heterosexual men, the blue one is women, the red line is MSM. And what I think you can appreciate is we have had over 20 years this steady decline in the number of visits by heterosexual men and women, and concurrent with this, a dramatic increase in the number of people we're seeing who are mental health sexual offenders, such that at this point, 44% of all visits to our clinic are by mental health sexual men, which is the largest single component of the population that we're serving. This slide is showing you trends in HIV, publicly funded HIV testing among MSM and HIV test positivity among MSM. What we've had is an increasing concentration of the testing on MSM. So we have a 26% increase in HIV testing among MSM over the last 6 years, even though the number of publicly funded HIV tests in King County has declined. And concurrent with that, we've seen a dramatic 47% decline in HIV test positivity among MSM. So we've gone from about 3% to about 1.5% HIV positivity among publicly funded tests in gay men. This slide is showing you where our HIV test people are HIV diagnosed in King County. 25% of all new cases are diagnosed in the STD clinic. Another 12% are diagnosed in publicly funded sites. Another 14% by MSM HIV specialty providers. So 51% of all the cases in the county are being diagnosed in an infrastructure which is specifically designed to address the needs of mental health sexual men and the highest risk population. And this is our estimate of the proportion of HIV infections which are undiagnosed in King County. So we think that 5.8% of all infections in MSM are undiagnosed. So less than a third of what CDC estimates for the country as a whole. We do see higher rates of or estimate that there are higher levels of undiagnosed infection in Black and Hispanic MSM, which may be true in the country as a whole. And the methodology we've used here is a new methodology developed by Ian Fellows and Martina Morris using intertest interval. But the point here is that we're seeing a lot of success. And this is our care continuum. I have to say I am proud of this and the work that a lot of people have done to achieve this in our community. So we think we're 92% diagnosed. Essentially, everyone is linked to care. We're 79% retained in care. We're 69% virologically suppressed, which includes the undiagnosed people. So a level of virologic suppression, which is higher than the United Kingdom, very much higher than observed elsewhere in the United States. But there may be other places which are comparable, although I haven't seen it. And here you're seeing trends overall. So we have a 26% reduction in new HIV diagnoses, a 58% reduction in AIDS diagnoses, a 33% reduction in mortality in people living with HIV infection. So we are achieving all of the goals of the national strategy, essentially, or virtually all the goals of the national strategy in King County in terms of trends. So against that background, which is a background in which it's going to be hard to find new HIV cases and move that continuum further, what are our goals? So our first goal is to increase HIV testing in index cases in the sex partners of people with bacterial STIs. We want to increase that population's testing frequency. We want to increase insurance coverage, and we want to ensure higher levels of linkage and sustained engagement in care in ART use. So there is probably no risk factor which more consistently identifies a population at high risk for HIV than having a bacterial infectious transmission. The figure in this slide is showing you the percent of MSM without a prior HIV diagnosis who will be newly diagnosed with HIV infection concurrent with the diagnosis of bacterial STI. So almost 11% of MSM with early syphilis will be newly diagnosed with HIV infection concurrent with their syphilis diagnosis. Almost 5% of MSM with gonorrhea, almost 3.5% of people are MSM with chlamydial infection. Now, remember, this is in an environment where the overall positivity, even in an STD clinic among MSM, is only 1.5%. Now, despite this, based on SSUN data, only 56% of MSM with gonorrhea in the United States are tested for HIV infection concurrent with that gonococcal diagnosis. So a goal needs to be to test these guys. And in building a system to do that, I want to point out, I do recognize that there are certain aspects of Washington State which are exceptional for us. So the first is we're starting with a system of partner services, which is probably a little more developed than much of the United States, and I talked to you already about that in discussing our ECT trial. And the other thing I want to point out is that our provider case reports include gender of sex partners. And the fact that they include that actually, I think, is a consequence of some good judgments made by Mark Alban and Mark Stanger at our state to add that to our case report form. So we have an ability to identify MSM at a population level among living bacterial STIs. So our goal was to test all MSM with bacterial STD and all of their sex partners, which we undertook using Category C funding. Here you're looking at the percent of MSM with bacterial STIs tested for HIV in a 20-month pre-intervention period before we instituted this change. What you can see is that the levels of testing, if you were seen by a specialty provider, were high. So in King County, 82%, outside of King County, elsewhere in Washington, 85%. In King County, most of the bacterial STIs and MSM are diagnosed in these specialty centers. In STD clinics, by CBOs that do STD testing, funded through public health by specialty providers. The level of testing is much lower outside of those specialty settings, and those non-specialty settings are the dominant settings once you leave Seattle. So the vast majority of STIs and MSM outside of Seattle are being diagnosed not in specialty settings. So with the institution of our intervention, you can see a huge increase in HIV testing, particularly in these non-specialty settings where we were previously falling short. That's a 23% increase overall in the proportion of MSM with bacterial STIs who are tested for HIV concurrent with their bacterial STD diagnosis or treatment. And that's how this is significant. Now here you're looking at the number of new HIV diagnoses occurring in MSM with bacterial STIs. The red bars are our pre-intervention period. The yellow bars are our intervention period. You can appreciate this big increase in the number of people being diagnosed with HIV infection concurrent with a bacterial STI diagnosis, particularly gonorrhea and chlamydia, which was our focus. Here you're looking at the proportion of all people with a bacterial STI who are newly diagnosed. And remember that this also includes the people who aren't tested. It's based on surveillance data. This was not statistically significant. And I think the thing one has to keep in mind here is that there was an increase in bacterial STI diagnoses in this time as we rolled out extragenital testing. Now, I mentioned to you that our goal was also to increase testing among sex partners. And let me take you to this slide, it's a little bit complicated. We divided the population of people with bacterial STIs up hierarchically. So the first bar on the far end is people newly diagnosed HIV infection and bacterial STI. Those people always would have received partner services. The second group is people with syphilis. Those people would always have received partner services, at least in a place like Washington State. The next one over is people who have gonorrhea or chlamydia and a prior HIV diagnosis. They would not typically receive partner services in the United States. The next group is people with MSM with gonorrhea, and the third group, MSM with chlamydia. Those groups would also not typically receive partner services. And these are the number of partners newly diagnosed with HIV infection. And the NNTI, remember, is number needed to interview or to investigate how many people needed to receive the service to identify a new case. And here, I've limited that to people who were newly diagnosed after the patient, after the index patient received DIS services. Remember, you don't really get to take credit for it if the patient did it on their own. The numbers aren't huge, but you're adding additional cases. And I think one of the real lessons, particularly if you're working in the environment with a low number of undiagnosed cases, there are no home runs. Everything is a small incremental step forward. So what I think we learned here was we knew that MSM and bacterial STIs were very high risk. We have an intervention that increases testing, and I'm actually quite confident of that. And that was particularly true in non-specialty settings. So it will vary in the United States if we were to roll this out. The number of new cases identified through the intervention, I think, is less certain because this is not a randomized controlled trial. As I said, I think we did increase bacterial STI screening concurrent with this, so some of this may have reflected that. The program costs for the state for that 20 months was about $530,000, would be my estimate. And I think the best estimate I come up with is that we identified about 39 new HIV cases. If we compared the level of the testing that we had compared to what is observed nationally in SSUN, and we add in those new cases and partners diagnosed after the provision of partner services, that gives me a cost per case detected of $13,590. Now, that may look like a lot to you. I'm going to come back to that in a minute. From our perspective, actually, that's not a bad value. Now, the second goal we wanted to promote in partner services for bacterial STI is increasing HIV STD testing frequency. We know from mathematical modeling data, some of which came from our group, but other models as well, that if we can increase the testing frequency and decrease the period of time that people are infected and unaware of it, we can decrease HIV incidence. And we have these data from Australia that Chris Bourne published a couple of years ago now, that text messages can be used to increase testing frequency in men with sexual men. So this wasn't a randomized controlled trial, but the yellow bar here is their pre-intervention period. The blue one is people, men with sexual men, seeing their STD clinic who did receive the text messages, and the red bar is the MSM who did receive the text messages. I think you can see about a doubling of testing rates in the next 9 months among short messaging recipients. So we now offer automated SMS messages to all men who have sex with men. Actually, we're offering this to heterosexual as well, who receive partner services. So it's a population-based intervention to promote increased HIV STD testing. Only about 25% of people accept this intervention. About 7% are already receiving it. And, but we're early in this. I think we can do a better job as time goes on. And I think the objective we're shooting for is that when you talk to somebody, you want to make sure, so what's your retesting plan? How will you move this forward? Because a lot of the reason people don't want short messaging things is they already put it in their phone. They have other ways, people have other ways of reminding themselves to do this. What we want is everybody to have a way that's going to work for them. Washington State is a Medicaid expansion state. We are committed to seeing our population insured and facilitating that happens. So we have an inpatient assister in our STD clinic, and we now ask everyone who receives partner services, are you insured and do you need assistance obtaining insurance? So you can see about 50% of people are already insured. Of those who are not insured, about half will take at least some information or some sort of assistance in order to do this. We've signed about a little over 200 people up since January, so we didn't have a great functioning site initially, but our site is working well now. We're able to go forward with this. We're going to need more data on this, but again, this is one of those things we can chip away at the problem gradually and eventually get there, and I think this is an opportunity for us. Here you're looking at the incidence of HIV diagnoses in MSM of bacterial STI. Now, before I had shown you data of this very high prevalence of undiagnosed HIV and MSM with bacterial STI. Here you're looking at incidence following an STD diagnosis. And similar sorts of numbers have come out of New York. What we're seeing is that the incidence of new HIV diagnosis among MSM with syphilis is 4.3% per year. And it's 2.3% for gonorrhea, about 1% for chlamydia, about 7% for MSM overall in King County. So these are very high rates. And our goal is to use this as a population-based platform for the promotion of PrEP. So we have already, we'll be starting a PrEP program in our STD clinic this year. I'm hoping we'll be getting going in April or May. We're already asking HIV-negative MSM whether they're interested in participating in that and collating those lists to call the guys back. So far, about 20% of people say they're interested in PrEP. But again, this is very early on. I think that potentially we'll see higher levels of interest, although I don't know that. As we move along, I think we'll probably ultimately expand to rectal gonorrhea as well. We'll have to see, but this is an approach to targeted promotion of PrEP to the highest risk population. And finally, we're using the partner services to ensure engagement in care and promote ART use. So we, over the 20 months of our evaluation period, we had over 800 HIV-positive MSM receiving STD partner services. Almost all of these patients will say that they have a medical provider, but almost a quarter are not on antiretroviral therapy. Those people are referred into a program designed to promote the use of antiretroviral therapy. And in those rare instances where people are truly out of care, we do refer them in as well. So I've been talking about what are the extra things we could do related to STD partner services or STD field services to advance our broad public health objectives. But the same thing exists in terms of HIV partner services. And the goal here is integration of surveillance and public health outreach. And what we want to do is we want to increase case finding, we want to increase linkage to care, we want to assure sustained engagement in care and virologic suppression, and we want to improve our surveillance. The data supporting HIV partner services as a means to identify persons with undiagnosed HIV are actually relatively weak. So we have a single randomized controlled trial. It was conducted in the late 1980s, early 1990s in North Carolina. We enrolled only 74 people. The men or the patients, most of whom were MSM, were randomly assigned to conditional referral, which is to say you need to get your partners notified. If you don't do it within some specified period of time, then I will contact them for you, versus patient referral, which was that the referral was left to the patients themselves. What you can see is that the percent notified, the percent of partners notified was 50% versus 6%, which was statistically significant. But it's something I want to point out to you is only 16% of men in the patient or patients in the patient referral arm referred any sex partners for testing. And when you look at that against more recent data, it really doesn't appear to hold up. So the more recent studies would all suggest that the patients do a much better job left to their own devices than they did in late 1980s North Carolina. That it really is a different era. So, you know, late 1980s North Carolina is tough. No effective antiretroviral therapy. I think a very different era in terms of how people thought about HIV. And almost all of the assessments of partner services, including the cost-effectiveness analyses, have assumed that the patients do what they did in this trial, which I think is simply untrue. So these data are a more contemporary experience with HIV partner services. So partner services in Washington State and in King County are linked to surveillance. We attempt to work every single case. Here, during this period between 2010 and the middle of 2013, we had a little over 1,000 cases. 76% of people were successfully interviewed. 71% of those people provided information about at least one sex partner. They named a little over 1,100 partners. And of those partners, about a quarter had previously diagnosed HIV infection. Of the people who tested, almost a little over a quarter were newly diagnosed HIV positive. So a very high rate of HIV positivity from my perspective in this population. But if you look at when the partners were diagnosed, almost 75% of the partners who were newly diagnosed were diagnosed before we actually interviewed the investigation for partner services. In other words, the patients accomplished this on their own. It wasn't a consequence of a public health activity. So if you think about it overall, yes, we had this 28% positivity. The number needed to investigate was 11.7 overall, which is dead on the national estimate, which I think Matt Hogman came up with several years ago. So it's exactly the same as what you see essentially in the United States as a whole. But if you only focus on what I think was legitimately accomplished, that number needed to investigate is closer to 47. So, not a home run. And this slide is showing you the cost per case detected through different public health activities in King County, Washington. So HIV testing in STD clinics costs about $23,000, $24,000 per case detected. But I want to tell you that the way I calculate this is I assume the cost, all of the costs for every gay man seen in our STD clinic are an HIV prevention activity that fits into this. Their gonorrhea, chlamydia test, everything is an HIV prevention activity. Because that's the way we have to fund it from a programmatic perspective. If we didn't have that money, we have to close the clinic, which is the #1 diagnosing site for HIV infection in the Pacific Northwest quadrant of the United States. HIV testing via community-based testing efforts is about $15,000, though if you add in the cost of the gonorrhea chlamydia test, which we also do in that population, that drives it a little over $25,000. So pretty similar, actually, to what we see in our STD clinic. HIV Partner Services is probably more expensive, more in the range of $32,000. And the integration of HIV testing promotion into the provision of bacterial STD partner services is actually the cheapest approach. That's only about $13,500. So, my methodology here is I grant you not unassailable. There's always going to be assumptions in how you do this kind of costing. But I think it gives you a sense of where we're at. But in the same way that we've had too narrow an idea of what was the objective of STD partner services, we've been too narrow in thinking about what the objective is for HIV partner services. So here what you're looking at is trends in King County in the percentage of people newly diagnosed HIV who have laboratory evidence of linkage to care within 3 months of their HIV diagnosis. And we're currently at a point where we're in the 95% range, which is to say essentially everybody links to care. And this is accomplished in large measure because HIV linkage to care is an explicit objective of our investigations. We do not close these investigations until the patient linked. Every case is reviewed at a conference every month that is attended by surveillance, DIS, and our program leadership to assure that every patient links to care. And our observation, which I grant you is not a randomized controlled trial, if you look at data from New York, they are likewise seeing a higher level of linkage to care among people who are receiving partner services versus those who don't. That was 79% versus 66%. So that really may be where the value is in much of these investigations. There's also value in doing case investigation related to cleaning up the surveillance data. So overall, we've had over 13,000 people who reported HIV infection in King County, Washington. And using our standard surveillance approach, we would say that we had 7,379 people living with HIV. But we have conducted a vast number of investigations of people who appear to be out of care. So we've done over 2,500 of these investigations. We've done actually more than that now, but that was as of the time of this publication. These are people who had at least a 12-month gap in care between 2006 and 2010. Of that group, almost 1,200 had left the area and 180 had died. So instead of having almost 7,400 people, we have 5,975 people in HIV. 53% of the people who appeared to be out of the care had migrated out of the area or died, and 80% of those people had migrated and left the state of Washington, or so we believe. So case investigation demonstrated that we had a 19% overestimate in the number of people living with HIV in King County. Well, this is what that does to your care continuum, to your care cascade. So the red bars are what that cascade would look like if we used our standard surveillance. We would say we're at 50% virologic suppression. But once you've done those case investigations to identify all those people who have left, we're at 69% virologic suppression. So that's what's required, I think, to get it. Now, what you could say, well, this is just a King County phenomenon, right? Seattle. I don't think that's true. Unfortunately, almost all of our data at present that I'm aware of come from the Western United States. But if you look at this, you can see it's 54%, as I mentioned, in King County. In Alaska, which has done a terrific job of doing this, using also a 12-month gap of care to see people who are out of care, but going all the way back to 1985, which we didn't do, they were able to confirm that 36% of the people had migrated or died. In Portland, Oregon, using an 18-month gap of care, so a little bit longer, 72% of the people who appeared to be out of care had migrated or died. San Francisco used a much narrower diagnosis, so what they've done is they've looked at people who had laboratory evidence of being in care 9 to 12 months ago, but no subsequent evidence of being in care. 32% of those people had migrated or died. And in Denver, a more restricted analysis focused on just people who have a 6-month gap in care, 27% have migrated out or died. consistently across these things, the population is extremely mobile. So these are the most recent that I'm aware of national data focusing on the 19 jurisdictions that have reportable CD4 viral loads. The estimate is 36% virologic suppression. Here I've taken CDC's estimates on undiagnosed infection and applied it to these data. And if we assume the migration was similar to what we see in Seattle, only looking at the out-of-state migration, so not with in-state migration, you'd have a virologic suppression of 46% for the United States, at least in these 19 jurisdictions. So quite a bit different from the kind of picture that I think we've been promoting to some extent as our surveillance system evolves and we consider these things. So I would just point out to you, these are enhanced data of the proportion of people with other chronic diseases that have achieved the goals of therapy. So 55% of people with diabetes have a hemoglobin A1C less than 7. 47% of people with hypertension have managed to control their hypertension. 37% of people with hypercholesterolemia. In other words, HIV is really pretty much probably about where chronic diseases are. And HIV in a place like Seattle is a model for where chronic diseases can probably be. So I think the public health system and the Ryan White program have been extremely effective in many parts of the United States in assuring patients get what they really need to save their lives. Now, I mentioned here that we also want to ensure that we're using the surveillance data to ensure that everybody is getting the treatment they need in virologic suppression. So we have a program which has been spearheaded by Julia Dombrowski in our group of surveillance-based re-engagement in care called CAP, Care and ART Promotion Program. We started out with this with 1,400 people with CD4 counts less than 500 infectable viral loads. Of that group, it turns out only about half are eligible for the intervention, most frequently because, in fact, they are undetectable, but our surveillance systems had captured or they had moved. And of that group, we've successfully contacted 37%. The biggest reasons we haven't been successful in contacting people is that we can't get a hold of them. In some instances, providers have refused to allow us to contact their patients, but I'd point out that's going to get better. Anytime you institute a new public health intervention, there'll be people who are reluctant. Over time, that gets better. 83% of people have accepted to participate in the program when we contacted them. So 26% of the eligibles have participated. And of those people, we've managed to relink or have pending appointments on 91 people. So the number needed to investigate here is 16. And it's a little hard to know what that exactly means because I don't have that comparable metric from other places. So what I would say here is, this is preliminary data. We'll have a final evaluation done in 2014. We rolled this out using a stepwise randomized design similar to what I described for you for our EPT trial. So I think we are going to have a strong design for our evaluation. I'd say given the current state of surveillance, a large proportion of people who are out of care have probably migrated out of the area or, in fact, are in care or dead. And the good of that is that our HIV Care Cascade, I think, is a lot better than what we've been saying. And the bad part of it is that the cost per person successfully linked to care is likely to be high. At the same time, I think this will become more efficient as the surveillance data improves. That we'll get through this backlog of people who probably moved out of our areas years and years ago. And the national data are going to get better and will feed back to us so that we can have fewer investigations. And I know CDC is working on that, and it's a high priority. In the interim, we do have an approach of risk scoring the patients to prioritize the investigations. And this, again, was presented by Julie Dombrowski at CROI just a couple weeks ago. And the factors in the risk score are time since last labs and surveillance and where you were originally diagnosed. If we had restricted our investigations to people who had laboratories sometime in the preceding 7 years and who had originally been diagnosed in King County, we could have identified 82% of the people who ultimately proved to be contactable with only 39% of the investigation. So I think it is possible to prioritize the cases for the objective of improving efficiency. So I do have a few conclusions about how we move forward. And the first has to do with our infrastructure. In general, the control of generalized epidemics of STI, epidemics of things like chlamydia, herpes, HPV, rely on the primary care infrastructure. And EPT is an intervention built around the primary care infrastructure. But the control of concentrated epidemics of HIV, of syphilis, in some places of gonorrhea, really are going to require a complementary specialized infrastructure. STD clinics, community-based organizations that test for HIV STD, MSM specialty medical providers. And the sorts of field services that I've been talking about here are very dependent on the existence of that clinical infrastructure, that specialized infrastructure. So we need to sustain and make that infrastructure better. I would also point out that our existing data collection is not going to be adequate to monitor the outcomes that I've been talking about. And as we think about what that's going to require, we're going to need some discipline, because nothing makes the GIS crazier than people like me telling them to collect too much data. I'd also point out that for HIV, we're going to have to move from cross-sectional data collection to longitudinal data collection. We're following people through a long-term process. That's a much more challenging data management problem than just case investigation. From a practical perspective, I would say that EPT can be brought to scale. I believe that communicable disease control is a public health obligation, and that we need to buy these meds as a group, the same way we buy vaccines in a place like Washington State. I think partner services for STD for MSM can be reorganized to achieve much more diverse objectives. Those include HIV case finding, increasing testing frequency, relinkage to care, PrEP, and insurance. But how well these new objectives can be met in diverse settings, I don't know, and needs to really be an area for program science research. I would point out that the integration of HIV STD fundamentally changes our funding opportunities and the cost effectiveness issues related to STD partner services. And that insofar as STD partner services advances HIV prevention objectives, programs should be considering using HIV prevention money to fund STD HIV prevention services. As I mentioned to you, essentially all of the visits by uninsured MSM and our STD clinics are funded on HIV prevention money. Without that money, we would not be able to have the clinics we have, which is our #1 diagnosing site for our quadrant of the United States. I think we need to reorganize HIV field services into a longitudinal process that follows people through this care cascade. And surveillance-based relinkage might prove to be pretty expensive. I also want to point out to you, though, that surveillance-based relinkage is not instead of clinic-based relinkage. What we're looking to develop is a planned redundancy with complementary efforts to ensure that everybody is getting what they need to save their lives and keep them in care and receive antiretroviral therapy. I think there's really a critical need at this point for data from outside the Western United States and additional efforts to assess needs to efficiently triage cases for surveillance-based investigation. And I want to just say that achieving high levels of viral suppression can be done. This is an achievable objective. And I think I've shown you data to demonstrate that's true. Accurately measuring the HIV Care Cascade, I believe, currently requires significant case investigation. But that can be done on random samples of patients, and I know the CDC is talking about that as a change in how MMP is organized, which I think is a good idea. The surveillance data are improving, which gives us, I think, new opportunities. But at the same time, because the quality of our surveillance data is changing concurrently with changes in population-level treatment, evaluating trends is going to be very tough. Because will changes be a result of a maturing surveillance system, or will they represent true progress? And that's going to be a big challenge for all of us. So all the work I've been showing you has really been undertaken as a collaboration between the University of Washington Public Health King County and the Washington State Department of Health. We could not do this work without the work of our DIS, who are really the workhorses of everything I've been showing you. I do want to, in particular, mention Julie Dombrowski, who's really been the person spearheading the HIV-associated work related to re-engagement and has been a star in this. And finally, since I know there are hopefully there are people watching this on the internet or who will watch it, the University of Washington and Public Health King County, we think we have a national mission We want to help you insofar as we can. We don't have all the answers, but we're delighted to hear from you. We have protocols that we're happy to share, just so you know. So that's my last slide. Questions, comments?
Again, to ask a question on the phone, please press *1. Record your name when prompted, and please unmute your phone before you record your name. Again, *1 and record your name. One moment for the first question.
Great to see you, Matt, and great wide-ranging presentation. As Category C coordinator here at CDC, I just wanted to make a couple comments. Our quantitative data are just starting to trickle in now, and for Cat C, the numbers and the percents are actually beating CDC FOA requirements for Category A and B for new positivity, which is great. For linkage and re-engagement percentages, we're beating the literature so far, so I'm really hoping this trend continues. And I think that's great for this program science work. My second comment is what I've noticed is for the grantees who are doing more what I'll call pure program, I've noticed they have certain struggles. For grantees who are more science-focused, really coming close to the edge of research, they have different types of struggles. Cat C program science is about high impact. And I think your project is a great example of in between that's going for high impact. It's program money. It's bringing the scientists in to support program and to work on high impact. So I just wanted to thank you for that and hope to the degree that that helps other people think about how best to do program science under the rubric of program.
Thanks for that, John.
Hey, Matt. Well, it's kind of mind-boggling the amount of stuff you just presented. It's kind of you sort of molesting the elephant in terms of even to pick on any one part of it.
I'm not sure I understand what that means, though.
So a couple of things. One is that that whole comparing the cascade with the performance in the chronic arena. Well, in some ways everybody knows that's bad, and so there's all this money being invested in fixing that. I guess is there any way in terms of the investment into management of chronic diseases that that this effort can be piggybacked on what's happening in Washington in terms of the management of chronic diseases and taking advantage of the investment of community health workers and making the system work better rather than separating disease by disease? Second thing, that issue about lowering community-level prevalence of chlamydia was always an extraordinarily high bar that you put in front of yourself, right? I mean, to think with that one intervention, you would make chlamydia, it would have an overall impact when it's a function of so many other things, the percentage of people that are in screening, that are tested, all that other sort of stuff. And so, I mean, I applaud you being so honest, but boy, it's a lot of work to have a non-significant result. Where you really, the recommendations, you've shown, I think, that it makes sense to use that as an operational approach to get what you want done. And in terms of it being a public health kind of investment, in Massachusetts, they decided there wasn't enough money in the system to pay for they withdrew funding for vaccines, and there's a trust set up that, the payers pay into to provide that resource. I was wondering to what extent you think it's feasible to avoid the free rider problem and have a proportional sharing across the payers based on who their index cases are to support that kind of activity, assuming you can make the case for it being cost savings to the community.
So Stu raised a lot of points. I'm not sure I can address them all. In terms of the cost sharing, you probably have a better sense of this than I do. I think the biggest challenge to me on that is, can you get this high enough on the agenda of these various insurers to make that happen? And I'm not sure that something like patient-delivered partner therapy is going to end up being a priority given the number of things that the healthcare authorities are trying to deal with. Vaccines are kind of bigger, and they have to do with all the kids are supposed to get it, and so that might be an easier sell. You may have a better sense of that than I do. In terms of, why do I think, what could we learn from chronic disease overall? from HIV? To me, it's probably the caseworkers. The reality is that Ryan White afforded us an integrated approach to the provision of care that no one else has. I mean, all of the I work in a Ryan White clinic. I've been an HIV doctor for 20 years. I'm a primary care provider. You know, all of my patients have a caseworker who need them. I talk to those caseworkers all the time. We have psych in the clinic. I don't need to find a different psychiatrist or refer them out. We have it there. The Ryan White system has actually worked quite well. I'm sure, you know, it has its problems like any other government program, but it does work. And I don't think people with COPD or CHF or diabetes enjoy that same quality of integrated care. So I think that's a big part of what's been different. Oh, I think that there was somebody.
Excuse me, there is a phone question.
Okay, how do I?
The phone question is from Deanna Hosley. Ma'am, your line is open.
Okay, hi. I'm from Georgia, and I was just curious on, did y'all keep up with who was prescribed or currently taking ART? Did you keep up with it clinic-based, or did you use the numbers for MMP, or how do you assess for the ART usage?
So our care cascades actually don't include a bar, which is ART use, because just as you've indicated, that's actually very hard to get at. So what we focus on is virologic suppression, and because all CD4 constant viral loads are reportable in the state of Washington, we can use that to look at that. But though, as I said, the surveillance system is imperfect, and so you need to correct it some using case investigation, although that mostly has to do with identifying the outliers. All right, well, thank you very much.
Thank you very much, Matt. If you want further discussions with Dr. Golden, at 1 o'clock in 1A in this building, there will be a group discussion. Everybody is welcome to join us.
And that concludes your conference call. You may disconnect at this time. Again, your conference call has ended and you may disconnect.